Welcome everyone. Thank you for joining us today. I'm Theresa Marentette, CEO and Chief Nursing Officer of the Windsor-Essex County Health Unit. Overall, 10,012 individuals have been tested for COVID-19 in our community. Currently, we have 1,420 tests that are pending. For those of you who are awaiting test results for COVID-19, please check the Ministry of Health's online portal or the link on our website. Please remember that while you are awaiting your results, you must remain in self-isolation. I will now share the most current case counts. There are 64,922 confirmed cases of COVID-19 in Canada and 19,121 cases in Ontario. Chatham-Kent has 89 cases and Sarnia-Lambton has reported 193 cases. Michigan now has 45,646 cases, with 9,566 cases being in Detroit. Today, we are reporting 685 cases of COVID-19 in our community, an increase of 11 cases from yesterday. 40% of our cases have occurred in long-term care homes and retirement homes, including both residents and staff. 252 cases have resolved. 21 people are in hospital. 16% of our cases are between the ages of 20 and 29. 16% are between the ages of 50 and 59, and 21% of our cases are 80 years and older. 42% are male, and 57% are female, and 1% is unknown at this time. Our community has lost a total of 58 people to COVID. 44 deaths have occurred among residents in long-term care and retirement homes. Our health unit is working with 11 long-term care and retirement homes that are currently experiencing COVID-19 outbreaks. Testing for COVID-19 is based on a clinical assessment. Common symptoms of COVID-19 include fever, a new or worsening cough, and shortness of breath. However, other symptoms may be present, such as a sore throat, unexplained fatigue, an increase in falls, nausea, vomiting, chills, headaches. If you are feeling unwell and need to seek a health assessment for COVID-19, there are several options. Complete the online self-assessment tool available at ontario.ca, contact Telehealth Ontario, or call your primary care provider for a phone or virtual assessment. To access a local healthcare provider, walk-in clinic, or virtual medical assessment, please visit eHealthWindsor-Essex.ca. Windsor-Essex has 2 COVID-19 assessment centers, Erie Shores Healthcare in Leamington and Windsor Regional Hospital Olette Campus. Please note that testing is available for people who have symptoms of COVID-19. Please continue to visit WECHU.org for the most current information and case counts. As we go into the weekend, I want to wish all the mothers out there a very happy Mother's Day. And to my own mother, who turns 88 on Mother's Day, happy birthday, Mom, I love you. I will now turn it over to Dr. Wajid Ahmed, our Medical Officer of Health, for further updates regarding COVID-19.
Good morning, everyone. Today we are reporting one more death in a long-term care facility. A female in her hundreds passed away yesterday. I'd like to express my sympathies for the family for their loss, and our thoughts and prayers are with the family. It's like every Friday weekend, we present an epidemiological summary of all the cases of COVID-19 in our community. So we'll be doing exactly the same today. So very quickly, this is what we will cover in our presentation. I'll focus on the key points to answer some of the questions that everyone, including myself, ask every day. And the conclusion we will draw will be based on the data and will apply the evidence in making public health recommendations. So this figure looks at the percentage of emergency department visits that were based on one's symptoms and not an official diagnosis. This type of graph gives us an indication of something happening before we get an official diagnosis. This is what we call as surveillance, sentinel surveillance. And this is what it looked like over the time. And we can see the red spots where we probably have seen more cases or more people showing up with these symptoms, which could be suggestive of COVID or anything ranging from asthma, influenza, pneumonia suspects, or COVID. The epidemic curve or epicurve help us assess to see the progression of the disease, whether we're talking about in the community or in any kind of an outbreak situation. This particular epicurve is created to show the number of confirmed cases by symptom onset date. On your vertical axis, you have the number of confirmed cases, and on the horizontal axis, we have the date these cases started showing symptoms. This includes all cases, that is, in the community and cases in the long-term care homes. Symptoms onset date is important because it gives us a better idea when the infection and transmission happened. Please note that the data presented in the shaded area may not be reported yet to public health and may not be entirely accurate and subject to change. Day-to-day variation can vary significantly, and we know COVID-19 do not cause disease after immediate exposure. It may take up to 14 days to show symptoms. In order to minimize the impact of day-to-day variation, another way to look at the epicurve is to present a 3-day moving average. The 3-day moving average should capture day-to-day variation and will try to present a much better picture of when the transmission or infection is starting. We can see that roughly since the second or third week of April, the symptom onset date is going down and moving in the right direction. In other words, it is very likely that we passed our peak with respect to symptom onset. Thanks to everyone in the community in playing their part to stay indoors and following public health measures. Once again, please note that data presented in the shaded area may not be reported yet to public health and may not be entirely accurate and subject to change. We know we have a lot of our cases in the long-term care home and retirement home, and this particular epicurve was created to show the symptom onset date in the community and as well as the long-term care home. We can see that COVID-19 cases are now shifting more from community to a long-term care home. This epicurve that we also report on our website, there are a number of other useful information available on our website. It just shows the number of cases by its reporting date. The next logical question that comes to our mind is, Harvey, how are we comparing with the other regions or overall with the province? We looked at the regional and provincial rates per 100,000 population. We used the statistics to compare the number of cases based on the population size. Please note that this comparison does not account for variation in number of people in different age groups. For example, roughly 18% of our community members are seniors, that is age 65 years and older, and this is in comparison with the provincial average where 16% of seniors reside in this province. So we can see Windsor and Essex, we are significantly higher than the provincial average and also higher than our counterpart in Lambton County and Chatham-Kent. And even in Lambton County, the senior make up roughly around 21 to 22% of their population. We also know that Windsor and Essex has at least our cases, 41% of our cases are in the long-term care home. In Lambton, 25% of their cases are in long-term care home. And with a higher proportion of seniors in the long-term care home in our region, and also the 41% of our cases from our community in the long-term care home, this is probably one of the reasons that we are seeing a higher number of cases per 100,000 population in our region. The next question is, how about the testings and how many people are being tested every day? And among those who are tested, how many of them are coming back positive? This is an indicator to show how prevalent the disease is in our community. And if we do the math roughly, we have already tested close to 2.5% of our population. We tested more than 10,000, and on average from a 400,000 population, this roughly equates to 2.5% of our population that we have already tested. When the results are coming back with a high positivity, that means it's much more prevalent in our community, but we can see that the positivity is going down in our community. A large proportion of that is because of the long-term care home testing. We are testing everyone in the long-term care home, and that's why one of the reasons that we are seeing the decline in the positivity is because of those people who are in those long-term care homes. Another question that is frequently asked is about asymptomatic people coming back positive for COVID-19, and we did some proactive testing and we are sharing the data from at least 7 long-term care home and retirement home, where we tested roughly 946 residents and 437 staff in these facilities. This is a preliminary analysis of person positivity among symptomatic and asymptomatic individuals in these facilities. As you can see, that there's a significant variation between symptomatic staff and symptomatic residents, and asymptomatic staff and asymptomatic residents. Based on the preliminary data, we can say that roughly 4% of the residents within a long-term care home without any symptoms can be positive for COVID-19. And one of the reasons for those not showing symptoms is because majority of these individuals are old and frail, and they may not exhibit overt symptom, and some of them may already have some of these mild conditions that can mask the symptom of COVID-19. We also use our data to give a breakdown of age and gender distribution in our community, and the purpose of creating this graph is to show if there is a gender difference in getting infected. So far, we can see between men and women, it's fairly evenly split, except for those who are in the age group of 80 and 80 plus. The other distribution, what we are seeing is between the ages of 20 and 60, it is fairly evenly distributed across each of these age groups. This graph shows the distribution of COVID-19 cases by municipality, and no surprises there. More than 2/3 of the cases are in Windsor, and the rest, as we know, a significant number of people live in the city of Windsor. And we can see the distribution in other municipalities as well. One municipality in particular where you're seeing the second highest cases, it's partly due to the high number of cases in the long-term care home. We have to use a precaution while we are trying to interpret this graph. COVID-19 is prevalent in all the regions of Windsor and Essex, so no region or no municipality is better or worse than any other. So please take appropriate precaution irrespective of which municipalities you live in, and take all the precautions as recommended by public health. In the early part of the pandemic in Windsor-Essex, we saw more cases attributed to travel. So more recently, we are seeing more transmission between close contact, and in the middle, we saw more community transmission. We are seeing a decrease in the community transmission for some time now. Please note that the travel in the recent cases that we are showing as a result of travel are all attributed to a healthcare worker. And this also shows this particular graph. It also shows the impact of our measures. If we track down most of the cases to a close contact, that means we are reducing the community spread. If you look at the cases in the last few weeks, most of the new cases are happening in close contacts, which is a good thing from a public health control measure perspective. Looking further into the COVID-19 by healthcare worker status, and we can see roughly around 30% of the cases in our community are healthcare worker. And out of these 30% of the cases, 27% of them are travel to Michigan, which could mean that they are healthcare worker who are working in the Michigan area. Around 6% of the cases visited a healthcare facility before they got infected, and this highlights the importance of following the infection prevention and control guidelines as recommended by Public Health and the Infection Prevention Committee of the hospitals and the healthcare facilities. Looking further onto the risk factors, the most dominant risk factor we can identify is cardiovascular disease, followed by diabetes, asthma, and obesity. And this is no surprise, as we know that all these conditions are prevalent in our community, and we need to do a lot of good work in promoting better, healthier lifestyle to reduce the number of cases in our community with respect to cardiovascular disease, diabetes, and obesity in our region. A quick look at the cases and the symptoms. Majority of the symptoms are still presenting with cough, and this could be a worsening or new cough, but there are other symptoms that our individuals are presenting. Please note that cases can report more than one symptoms, and that is why these numbers may not add up to 100%. This particular graph shows the number of hospitalizations in patients in the ICU on a given day. It can include both new patient and existing patients with COVID-19. As we can see that there's a decrease in the number of cases ending up in the ICU in the past week. Our hospitalization haven't peaked as predicted, rather stabilized, and we have seen a decrease in the past 7 days. So where we are with all these cases, roughly 34% of the cases are resolved, 33% are self-isolating. Unfortunately, we lost at least 8.5% people who died as a result of COVID, and around 2.7% were hospitalized, and with a small portion ended up in ICU, and 22% are ongoing or unknown at this stage. So looking at the age and sex breakdown of COVID-19 deaths in our community, and we can see that majority of the death happened in individuals who are older than 80, and then we have one case at least in the 40s age group as well. Putting things into perspective, this particular graph shows that what it means for an individual who contracts COVID-19. In our community, the overall case fatality is 8.5%, and those who are living in the long-term care home and retirement facility, case fatality is significantly high, 15.6%, and that is why all the attention is now focused on this population. In the community, the case fatality rate is 3.5%, and overall, when we compare Windsor-Essex, where case fatality is 8.5%, compared to the province, where the case fatality is 6.7%. So in our community, the case fatality rate is high, and partly it's because due to the high case fatality rate in the long-term care home and retirement home. So the doubling time tell us how many days it will take to see twice as many COVID-19 cases in our region. It tells us how quickly COVID-19 is spreading in our area. These specific figures look at our doubling rate since our first case was reported. Currently, we are past 5 days doubling time, considering in late March and in April, we were doubling every 2 days. So this is a good progress, and we can see some of the impact of flattening in this particular graph. Another way to show case doubling time is to day-over-day comparison, and we are able to do that comparison compared to the province and also for the overall Canada in general. The higher the number, that means we are doing better. So if you're looking at the case doubling time overall, most of the time we stayed above the province doubling time, except for a few dips in the region, which was resulted in more cases in our community, and changed some of that graph for a short period of time. But overall, from a case doubling perspective, comparing with the province in Canada, we are in a better shape than the provincial average and the Canadian average. So I'll stop here and I'll take questions. Thank you.
We'll now take questions. We'll start with Blackburn.
Just looking at the pending tests and comparing it to all these statistics, when you get those test results back, do you put them as like when you took the test, or like just when you're looking at the timing of some of those graphs?
So it depends on the graph that we are presenting. So one of the epi curve that I presented was based on the symptom onset. So even if we are getting the results later on, we use that symptom onset date in that particular epi graph. If there was no symptoms, then we use the date when the test was taken.
So we wouldn't see a peak later on just because we are waiting so long for results?
That's why, like, if you're looking at, can we go back to the epi curve, please? So let me just try and explain that. Good. So for example, if we're looking at this graph, we have shaded the last 2 weeks for the data, and we have to use caution when we are interpreting those data, because that means there could be results that are delayed that we haven't received, and other than that, the rest of the graph, it seems the data is already, we have received the data and we have did the interview, and everything that is showing in before that shaded area should be as accurate as possible. The shaded area, that is subject to change, so that's why I won't put too much emphasis on interpreting that chart, but everything before that, we can say pretty certainly that we have the information that's available.
So when the government is looking at opening up, taking stages of opening up, and they're talking about, they need to see results for 2 to 4 weeks, are they looking at accurate data? I mean, obviously, we don't have the full picture down here.
So if you can see, when you're asking about 2 to 4 weeks worth of data, if you focus on in this particular graph that's right in front of your screen, we can say for certainty in the at least the 2 or 3 weeks in April, we were not seeing the peak. So it's pretty stabilized. And on an average, if you do go with the day-to-day comparison with So even if you're looking at this from a reporting date perspective, we're still getting the cases, but it is roughly hovering around between 10 to 15 cases on an average, and most days it's less than 10, and that is happening for almost a month now. So that's just ours. But when the province is looking, they're also looking at the similar data. Obviously, we cannot rely on the last 2 weeks data for sure, just because of those reporting delay reason. But anything that's happening before that 2 weeks, we can say with confidence that that's an accurate picture of what's happening and all the decisions that people are making. My impression is they must be looking at that data rather than the data from yesterday or the day before.
Any questions from CTV?
Just referencing the asymptomatic slide that you had earlier, I'm just curious, is there any talk at all of having residents randomly tested for symptoms like they are in the States?
So what is happening right now is we are testing everyone in the long-term care home and retirement home, and so that would give us a good baseline of what's happening in these facilities. And I think what needs to happen more is a good assessment, like a daily assessment, what we are talking about, which is happening right now, is twice daily temperature check, twice daily review of symptoms to make sure that we are not missing anything. But despite that, some individuals, if they have some kind of chronic cough, you cannot differentiate if it's a new cough or it's an old cough or it's getting bad or it's getting worse. It may take a couple of days before the symptoms can really become overtly symptomatic, and so there could be that delay. So I think it's just more about on surveillance and actively looking for those diseases. That will be helpful.
Even just for the general public, though, I guess I forget what state was doing. I think New York and California are doing this, where they're just randomly testing residents just to see who's walking around with the virus. I haven't heard anything on this side of the border, so I don't know if that's in discussions in the background or.
No, I think that should happen because that will be the only way we can speak with more confidence that people in the community, what's happening with them. Because we have a good assessment now on retirement home and long-term care home, we don't have that level of confidence to say what is happening with the asymptomatic people in the community. And again, this all needs to be balanced by the lab capacity and the ability for to test those individuals, and then what criteria that we will be using as who do we target for those asymptomatic people. So I think from a policy perspective, what we are seeing is identifying the high-risk population first, and to make sure that we have a better handle on these high-risk population. And then as we get a better handle on this group, then we'll talk more about mass testing based on, again, the testing capacity and the type of testing that is happening at the community level, at the population level. I think that should be the goal until we get to the point of having a vaccine and the appropriate treatment.
So do you see that happening at some point?
At some point, definitely, yes. Yeah, but when, I can't say.
Any questions from AM 800?
Yeah, you mentioned that the case fatality rate for long-term care homes locally is 15.6. What is it across Ontario?
I'll just flip back to that slide again.
Yeah, that's for long-term care is what I'm looking at.
So not in particular to the long-term care home. Sorry. So this is an aggregate for the entire comparison for the province, and the case fatality rate that we have presented for the province, it's an overall number, and just trying to get to that slide.
It's 6.7%, I believe, was
Yes.
the overall. Right?
Yes. 6.7 was the overall percentage for the province, and but our is overall 8.5%, and just in the long-term care home and retirement home is 15.6%. I don't have that level of breakdown for the province.
Okay, all right.
This is a general question, but I have to ask it. It's Mother's Day this weekend. How do we visit our mothers? Or not can we, how do we visit our mothers?
So I think it's a good question, and I would encourage people to try to make that virtual visit, and if it's not possible, people can try to take steps to ensure that they're not violating that physical distancing piece, and again, not congregating with more than 5 people in any public settings. And if they can meet that, I think that would be the best. And you have to be mindful, our mothers, our grandparents, they're all vulnerable, and anything bad that we can bring to them, it may not be a good thing. So as much as it's difficult and challenging to be with your mother, with your grandmother, you have to take precautions, and you have to apply more sense to how you are making that interaction. If it's possible through virtual means, that should be the goal. If not, then it's still trying to meet the 2 conditions as I identified.
Thank you.
Any questions from Windsor-Essex?
I think I missed it, but did you say what the population of the health unit is?
It's roughly 400,000, but again, that's old census data. The new estimate could be anywhere between 420 to 430,000 population, but we typically use the census data, which is roughly around 400,000 for the entire Windsor and Essex region.
So there was a chart going around on social media that shows a comparison of the number of cases in different regions. But what it's doing is it's comparing differently sized regions, such as comparing Windsor to New York or Windsor to Italy. And it's actually showing that we're pretty bad. I know that you guys do a comparison based on 100,000 population. Does it give a false impression when you compare large sized regions to small regions?
No, when you are, so in epidemiology, when you're making those comparisons, so we go with the population comparison, and that's where one of the graph, and if we can go back to Mark, One graph, it shows in particular that where we compared ourselves with our region, Sarnia-Lambton, Chatham-Kent, and then we also made that comparison to the province in terms of the case per 100,000 population. Yeah, so this is the graph. And so if you can see that from a provincial average is 128, provincial rate is, I shouldn't say average, provincial rate is 128.6 cases per 100,000 population. For our region, it's 156.3 per 100,000 population. So clearly we are higher than the provincial average and even from our neighboring community.
Any questions from the Windsor Star?
Yes, good morning. Now, with businesses opening up, is it reasonable to expect to see another spike in community spread, or can we mitigate that? Can we prevent that if we follow public health guidelines?
Even all the businesses that are opening up right now, they have to meet certain guidelines, especially with respect to physical distancing and what kind of shops are currently opening. And a lot of that is on individuals. When you are accessing those facilities, it doesn't mean that the pandemic is over. It still exists. The number of cases still exist in the community. And unless everyone take their part and everyone do their responsibility of maintaining physical distancing, ensuring that when they're sick, they're not going to these facilities and going only when it's essential. It's not that people should just make it out as just for a fun visit to go to these facilities. It's not that. It is only for the things that you need. So when everyone is following that, it will avoid that high number of people going to these shops, and also maintaining physical distancing and staying home will prevent some of these. But it is something that we are all waiting and watching it very carefully, because one or two bad moves can take us back to where we were. So we have to approach this very carefully and cautiously before we can say that it's safe and to open more stores or what the impact looks like. So we will be watching very closely.
Thank you.
Any questions from CBC?
Yes, good morning. We have it confirmed that about a quarter of the cases that resulted in deaths were from the field hospital. Are you surprised that that number is so high there, because initially it was meant for people with mild symptoms?
Well, we were watching those numbers day to day, and the intent was not to say that people who were transferred there were mild symptoms or had severe symptoms. It was more on the ability to for the homes to cohort those people. And when I say cohort, means like where there is the ability to keep the cases with separate from the non-cases, and the availability of the staffing and any other issues that the home may be experiencing. So that was not the criteria in my mind that was mild cases or severe cases. It was just based on the needs. And majority of those cases, as we have reported day to day, are elderly people with comorbidities. So yeah, it's a loss. And it was a tragic loss to the community. That's all I can say. But those deaths happened over a number of, over the period since these individuals moved to field hospitals.
Has moving them been good for the long-term care home that these residents were moved out of? Has it been positive?
So that's a good question that I think there's no easy answer to it. There are a number of factors that you have to consider before these type of moves happen, and identifying and making those decisions, it's never an easy decision. That is why there is the piece when before moving, it has to be ensured that the families or the individuals, they are aware of the risks and benefits of making that move. And there's always a risk. If you keep them at the home, there's a risk. If you move them to another facility, there's a risk. It's just about balancing the risk and finding what is the best solution for these residents. And it has to be an engaged conversation with either the individual themselves or the people who are caring for or are supposed to make decisions on their behalf.
So in the overall picture, it's just hard to define if this has been a good move or not.
It has to be balanced by the risks and benefits. There is no right answer. If you're looking for a right answer, I don't have a right answer. There's a risk, just like every decisions we make in clinical medicine. There's a risk. If you treat someone, there's a risk if you don't treat someone. And those individual decisions are made individually, and there is no right or wrong. It's just balancing those risks.
What I mean is the people that are at the long-term care home that are there now, still there, has moving the people out of that facility has it helped keep cases down now? That's more of what I'm asking.
Definitely, I think that was the decision to segregate people, because if there is any inability to separate the cases from non-cases, the likelihood of transmission is high. So that's the initial reason for separating these individuals one from another, and that's the goal in managing any of these outbreaks. And since that happened, obviously we haven't seen that many increase in the number of cases. There are still cases in these facilities, so we can't really say that it has just completely solved the problem. But I would definitely say that it solved the problem partially. And still there are other issues that goes into play, not just these individuals, whenever we are managing these outbreaks.
Okay, thank you.
Any further questions from Blackburn?
No, I'm good, thanks.
CTV? I'm good. AM 800?
No, I'm good, thank you.
There's a question from Radio Canada.
Oh, sorry.
Thank you. Good morning. I'd like to know if there's an expiration date for analyzing the samples. Like when there are delays in obtaining results, is there a risk that the samples will be unusable?
So by the time when a sample is collected, it has to be analyzed within 72 hours. And if for any reason that sample cannot be analyzed within 72 hours, it has to be stored in the refrigerator to allow for that extended timeline to be able to test the sample. So all these lab logistics that comes into play, and the labs take, for most of the part, either it happens for 72 hours or it's refrigerated to ensure that it happens in a timely manner without wasting the sample.
Thank you.
Any further questions from Windsorite?
No, I'm good, thanks.
Windsor Star?
No, thank you.
CBC?
No, thank you.
Radio Canada?
No, thank you.
Thank you, everyone.